Hi, this is Terri Diaz.
And I'm Robyn Towt.
And together we are creating GPAC, which means Global Patient Advocacy Coalition. Together we are collaborating with patient advocates all around the world.
We've seen the amazing work that our patient advocates are doing in various countries. And we want to support and encourage their efforts, share ideas, and help implement those ideas in other countries.
And what's really exciting is we're also starting a video series with specialists and experts that will share and educate on various topics, including those that relate to breast implant illness information and policy changes and legislation.
At GPAC, we are committed to working collaboratively to endorse and support our global advocates. And we want to implement positive changes in each country, utilizing the skills and network of our amazing colleagues.
We are so excited for you to join us, and we look forward to seeing you again.
Thanks.
Our first guest is Dr. Eduardo Fleury. Dr. Fleury is a board-certified radiologist, researcher, and professor of medicine with a Ph.D. in Gynecology and a Post-Doctorate in health sciences. He holds the title of EDBI, European Diploma in Breast Imaging, and is also a medical doctor in Portugal.
For 4 years, he studied the complication of breast implants. Dr. Fleury has just recently published his hypothesis: the breast tumor microenvironment, could silicone breast implants elicit breast carcinoma? This is what we will be discussing today.
Thank you, Dr. Fleury, for your time and dedication.
Thank you so much for everything you do, Dr. Fleury.
Hi, everyone. This is Terri and Robyn. We are here interviewing Dr. Eduardo Fleury. He just came out with a new publication called The Breast Tumor Microenvironment, Could Silicone Breast Implant Elicit Breast Carcinoma? And we are here to have a nice open discussion about this theory.
Thank you for the introduction. And it's a pleasure to be here and to share my research with you. You are doing a great work with the breast implant illness. And today I'm going to talk regarding it's an hypothesis. Yeah, it's not a research. We are just start this hypothesis of in our observation of some patients that we have in our study protocol here in Brazil. So this is the article that we are going to talk today. It's the breast tumor microenvironment, silicone breast implant breast carcinoma. It is published in this journal, the Breast Cancer Targets and Therapy, and it's available online, and it's an open access. Everyone can get the full article. Today I'm not going to explain the theory. It's hard to understand, especially for not a physician. But if you want to try to learn to read it, I think there's a lot of information, and I think it's very nice. So the relation between silicone implant and breast cancer is a lot of controversial, but if we search in the literature, we found some articles that they report the relation of free silicone and breast carcinoma. Here it's May of 1985. There is a case report, and one of the conclusions is, although no causal relationship between silicone and breast implant is implied, and they question if there is some relationship between the silicone and the breast cancer. We have here another publication on February 2015 on breast cancer originating from a silicone granuloma, a case report. And so it's another case 30 years later, and we have the same findings. And here's interesting, because here's in the article, we can see some features like This mass is not a typical mass that we find in breast cancers. That's not usual or trivial for our clinical practice. And this mass, we can find some snowstorm. This is implicit of the silicone and granuloma here. And here is the cancer. And it's interesting because we can see some foamy histiocytes here. And in between the cancer, we have some places that we have an inflammatory reaction. So this is what they reported, but they don't know why the cancer was elicited, if there is any relationship between the cancer and the microenvironment. And we have other cases of cancer. Here's a case of angiosarcoma associated with breast implant that was published in 2007. And it's interesting again because we can see here's the implant, and here's the pathology of the implant, and here's the mass. The mass is just behind the surface of the implant, and here's the mass, the sarcoma near the implant capsule, and just in contact with the breast implant. So here we saw some cases of breast cancers and sarcoma, and they related to the breast implant, but the association between, they don't know why if there is any relationship between the implant eliciting the breast cancer. Some concepts that's important to understand. Here we have a normal breast lobule, and when there is an injury in the lobule, we can trigger acinar ductal metaplasia. And especially here with the implants, we can see some cells that are important here. The T cell, the fibroblasts, the TAM, that's the macrophage. Here's the foamy histiocytes. And it's important to understand that this process, this inflammatory process here, they have some immunosuppressive molecules that can favor a growing of a cancer here. It's much more complex than I'm saying. I'm simplifying, but that's how probably this works. This is our theory. So we use our accumulated experience in our research in 5 years of a prospective study, where we especially studied the silicone-induced granuloma of breast implant capsule. And here we can see that we prove in our research that even when we have an intact implant, we have some gel bleeding, and this bleeding is toxic to the microenvironment of the implant, especially in the fibrous capsule. But at the beginning, we didn't pay much attention for the pericapsular space and the glandular tissue. In our hypothesis, we use some concepts like metaplasia, T cell dysfunction in cancer immunity, inhibitory cells in the tumor microenvironment, morphogenesis and bowel plan, and invasive cancer. So this is how we structure our theory. And we use some new concepts in our theory too, based on this article published on June 2020. They report the low molecular weight silicones inducing cell death in culture cells, especially a type of lymphocyte. It's a Jacquard cell. It's a kind of lymphocyte that they use in laboratory for its in vitro experience. And they concluded that the small particle of the silicone that is used, that particle usually bleeds. It's the polydimethylsiloxane PDM4, and this is the small and more toxic particle of the silicone. And this small particle could have some injury in some cells, especially on these cells, and they can induce to the death of these cells. So this article is also available on the internet. This is the figure of our Terri. So what happens here? Here is the implant, here's the intracapsular space, and here's the fibrous capsule. So during the time, we have a degradation of the shell of the implant, and we have inflow of the seroma or of the liquid that we have here, the fluid that we have here. We have a chemical reaction here, and with this chemical reaction, the silicone is going out of the implant and carrying especially the PDMS 4, 5, and 6. We are taking attention more on the PDMS 4. That's the smallest one and more toxic one. When it gets in contact with the fibrous capsule, it's going to have an inflammatory reaction. And here's the silicone-induced granuloma of the breast implant capsule. We have a lot of inflammation because the implant this is always occurring, and as we have the loss of the permeability, we have a chronic bleeding of the silicone. So once time, it's going to have an inflammatory reaction here, and it's going to solve by itself in approximately 3 weeks, and we have a scar here, and here's the granuloma. But the next time, probably it's going to elicit an inflammatory process of the fibrous capsule, and here it could explain the capsule contracture. It's interesting because most often all of these things, and it's what I report in all of my research, are restricted to the fibrous capsule, because the fibrous capsule is a barrier of the body against the foreign body, that's the silicone. And it's not that effective, but it's effective on protecting the breast. I say that's not that effective because the PDMS4 is lipophilic, it's lipophilic and hydrophobic. So it's going to, this PDMS4 is going to go outside the capsule, and probably it's going to reach all of the organs in the body, and this is what we think it's going to have the breast implant illness. So it's effective, the barrier is effective for the pericapsular space, but it's not going to protect against the bleeding to the whole body of this small particle. But here, when we have, if we have a rupture of this fibrous capsule, we are going to expose the breast tissue to this content, to this inflammatory content. And this inflammatory content is going to make an injury of the cells. So here's the cell. And here we have a direct injury of this fluid to the cells, like we compare here with the metaplasia we have in the esophagus, in the Barrett esophagus, and eliciting the cancer. So it's going to injure the cell, and as it's a constant injury, this cell is going to die and it's going to recruit a new one, and so you're going to have a reverse morphogenesis. So we're going to recruit more younger cells here, and these more undifferentiated cells, or we're going to have a metaplasia of the cells, and the cells are going to try to protect the body against this injury, and sometimes associated with the immunosuppressive of this inflammatory reaction, we could have dysfunction of the cells and going to carcinoma or metaplasia. So this is basically what we try to explain our theory. Do you understand all?
Mm-hmm.
Perfect. So it was very important for us to have a case that we could explain all of these steps, and with a well documented case. Yeah, and this patient, we follow up her for 2 years since we made the first diagnosis of breast cancer, and we tried to collect most of the data to support our theory. What was interesting here? Here is the left implant of the patient, and here's the posterior surface of the implant. So here you have a mass. This mass is a cystic mass, but a complex cystic mass. We have some vegetation in this mass. Here, we can see this vegetation. Here is some fluid inside of the mass. And what is interesting, here you can see a lesion that is aggressive, that we have a lot of turnover of cells because of the type of the imaging that we have here. But locally, it's not aggressive. So it was very interesting the first time I looked for this patient, because I've told we have an aggressive lesion here, but locally it's not aggressive, like a breast tumor or undifferentiated breast tumor. We perform. It's interesting here. And another things here, we could see that this patient have a rupture of the capsule of the implant, and this rupture communicates the tumor with the capsule. Another interesting thing here is this patient had the implant in less than 6 months. So she put the implant for static purpose, and 6 months after the surgery.
And you said there was no rupture at all?
There's no rupture here.
No rupture, okay.
Just to interrupt really quick, so it looks like that implant is being pushed then by the mass, because you can see it's a little bit deformed. So I was wondering if that was a rupture, but if that's not ruptured, is it because the mass?
No, this is the tumor, and this is the implant.
Okay.
Here's the capsule, and the capsule here should be homogeneous here and continuous, but here we have a rupture of the capsule.
Okay, I understand now.
That's what we say here. Probably we have a rupture of the capsule, and here we have the circulation of the. So all the collection that we probably used to have inside the capsule here, it goes outside the capsule and keeps in contact with the breast tissue, and probably made an injury on this breast tissue. So here's the ultrasound. The ultrasound, you can see that the breast implant has the texture of the implant is different here. So probably in our research, we can say that we have a chemical reaction here. Here is the capsule, and here we can see the degradation of the capsule, and here's the tumor with the vegetation. Here we can see it's vascularized tumor, and here with the Doppler we can see the vegetation of the tumor wall. And it's interesting here again because it's well delimited the tumor, because it was much more aggressive for the place inside than outside. So it looks like here the tumor is protecting the breast tissue. And this is not an unusual finding of a high-grade tumor. So that's why we keep interested in these cases. And here I understand at the beginning that we used to we should have an ALCL, a lymphoma, outside the capsule. It's my first diagnosis here. We made a PET-CT here, and we have the uptake of the mass, and here you can see the area that we have the communication between the implant and the mass. And this was the tumor. We made a biopsy, and it was totally undifferentiated tumor. It was impossible to say what kind of cells that we have here, but we can say that it was aggressive cells. At here it was the tumor. Here we have the vegetation. It's a cystic tumor. It's interesting again because it's well delimited. It don't have despite it's an invasive aggressive tumor, it is well delimited. So we don't have an infiltration of the breast parenchyma. And we opted here to make a surgical biopsy. So we took out the tumor. We keep the patient with the implants here. And with the diagnosis, we follow this patient with a chemotherapy and then a follow-up for a mastectomy. So this is the diagnosis of the undifferentiated breast tumor, high grade, and it was impossible to say that without the immunochemistry that this is breast tissue, but this tumor has some specific cells that say that, oh, these undifferentiated cells are from the epithelial cells of the implant. After the surgery, we made the first MRI 6 or 10 days after the surgery, and this was so impressive because we took away the tumor. Here we can see we have margins of tumor here, and so we don't took all of the tumor. Probably we expected to have a residual margins at the follow-up MRI, but here we can see rotation of the implant. So the posterior face of the implant here is medial and used to be lateral, and we don't have any residual tumor here. So it was very interesting. It's not usual, this kind of findings at in our practice. And after the chemotherapy, 3 months after the chemotherapy, this patient, we perform a breast MRI again, and at the same side or height of the tumor, but here the implant is rotated. We found a mass here with a contrast enhancement, and this is the silicone granuloma. So what we saw here, we saw that at the same site that at the implant that we have the tumor, here we have findings of SIGBIC or silicone induced granuloma. So we think here that we have probably something wrong with the implant at site. So it is at the surgery we try to search for something wrong with the implant. Here's the surgery of the capsule. Here in the capsule, we don't have any type of malignancy, so we don't have more the probably it could work by the chemotherapy, but after the surgery, we didn't find some residual tumor at the breast MRI. But here we can see findings of the granuloma of the SIGBIC. So we can see the fumis, ties, lymphocytes, especially the T lymphocytes. Here is the implant. The implant is intact, so we don't have looking for the implant. There's nothing with the implant, and we can see here this collection inside of the implant, and this is probably a reaction of the capsule to the gel bleeding. And here is the implant. This is interesting because despite the macroscopic integrity of the implant, here at the posterior face of the implant, we have discontinuity of the implant. So we have a exposure of the silicone inside of the implant. So here you can see the silicone inside of the implant having some reaction. Here we have some degradation of the shell of the implant. So this more white region here. And inside the implant, we can see some vascularizations. Here you can see some vascularization. So this here we have a chronic exposure of the silicone because we have a degradation of the shell, and this exposure, we think that it makes injury of the cells inside of the capsule or outside of the capsule, and when outside of the capsule, in our theory, it could elicit a breast carcinoma. So in our case, we only report what we found in this patient with many a well-documented case. So did you understand all of that I say here?
I have a question on your slide D. What is that exactly? I know that there's obviously
this is a degradation of the implant, and inside the implant here we have some in the MRI you can see it's a water droplet, but here we can see some blood inside the implant.
Oh, okay.
This red here. So we have probably a vascularization that goes inside the implant.
Okay. That's what I was curious.
So we needed more documented cases to validate our research, because here's a theory, and it's a disruptive theory, and at that time we have a second case that was very similar to the first one. So when we think in our theory, if there is cancer, there should be metaplasia. So metaplasia should go before the cancer. So if we have, if I'm presenting a case of cancer, probably we have much more benign lesions caused by the bleeded silicone. Here's an example of one patient. We don't have the histology of this patient, but here we have a heteromuscular implant, bilateral, with silicone-induced granuloma bilateral here, and we have pericapsular inflammation of the breast tissue here. So we have probably this patient. We don't have the histology of this patient, but she have an inflammatory reaction here with metaplasia of this tissue. And what's interesting, because the implant is intact, we don't have any signs of rupture of this implant, but we can see here are the granulomas, and in this case we can see some silicone in the lymph nodes. So we can see lymph nodes with silicone in the mammary chain here and in the axillary, in the axilla of the patient. So we have the bleeding of the silicone, and probably at that site we have a reaction of the the bleeded silicone and eliciting an inflammatory process at the breast tissue. So for the Terri validation, we needed a benign lesion to say that the Terri is plausible. The Terri is validated. And we had another case, a similar case. We have this patient with the breast implant here, with a mass that is very similar to that we described in our first research. And it has some similar points here. You can see the mass in contact with the breast implant. Here you can see the mass. And we have in the implant here a change of the sign of the implant. So this is the water droplet sign that it infers that we have the permeability loss of the shell. When we performed the ultrasound of this patient, we saw the mass here, just like the same of the other. It's circumscribed, well delimited lesion, but it's a complex lesion with the vegetation here. And with vascularity in the Doppler scan. And what was interesting in this case, when we look for the site of the water droplet here of the MRI, we can see there is an invasion of the mass to the implant. So this is it's not easy to find this, but if we try to search for these findings, you can find. So this patient went for a surgery. So here we made a excision of the mass, and we paint the implant at the site of the mass to search at microscopy what's happening here. So the implant is intact. There is no signs of rupture. So macroscopy, there's nothing to say about the implant. But when we perform the microscopy, here we can see some vessels inside of the implant. And here at this site, so where we color the implant, we could find a discontinuity of the shell. So when we pressure the implant, here's the discontinuity of the shell with the vessels inside, and probably there are cells and blood inside of the implant. So here we can see again that the mass has contact with the place of the implant, that we have a discontinuity of the shell. Here is a benign tumor. This is a papillary tumor. So with these two cases, we could validate that we have an aggression of the tissue, and this aggression of the tissue is causing the metaplasia, in one case for benign and in other for malignant one. And here's the benign lesion, it's a papillary lesion. And what is interesting here, we have the inflammatory process, a dense inflammatory process again, just like the same, having the same cells, Fumi, histiocytes, T lymphocyte, T cells, T lymphocytes, and we always have the same cells, the inflammatory process, and the metaplasia here as a benign lesion. So we have a case of breast cancer, of undifferentiated breast cancer, and a case of a benign lesion here, and both of them, we can show the relation between the discontinuity of the shell, the exposure of the silicone, and the eliciting the tumor growth, a benign and a malignant one. And what about silicone and DCIS? So here you have in between the benign and the malignant, probably you have the DCIS. This is an interesting case that the patient goes through the explantation, but the surgeon didn't perform the capsulectomy. So here, this is just after the surgery. At the pathology, it was a DCIS in the pathology. So this patient performed this MRI to follow up and to schedule the new surgery for the exeresis of the tumor, for the tumor resection. And here you can see a collection inside of the capsule, both capsules, and we can see we found some findings here of the granuloma, and we have pericapsular edema, and in both sides the beginning of the right and the left. The right we have more findings than the left, but they are just like the same. This is the ultrasound of the patient. Here's the capsule with the granulomas of the capsule and a collection inside of the capsule. And here's the pathology of the capsule. The right capsule, there is DCIS with FUMI, histiocytes, and polyurethane with giant cell. On the other breast, the left breast, we have synovial metaplasia with polyurethane and without signs of malignancy. So probably in one place, the implant elicit differentiation through DCIS, and on the other for a synovial place. Another case of DCIS with capsular contracture, signs of granuloma in the capsule, and here is the tumor. Here's the DCIS. Here's the DCIS just in contact with the fibrous capsule. And we have cases of DCI, of invasive breast cancer. This other patient, we have a cancer here. We have signs of the water droplet, of the permeability loss of the implant. We find some granulomas on the breast implant here. Here we can see the finding of the granuloma. And again, what's interesting, you have invasive ductal carcinoma with a dense inflammatory process with lymphocytes. So I don't have this is we look retrospectively in our study, all patients that had precancer and they had implants. We didn't, at the time of the study, we didn't pay attention for these patients, but when we look retrospectively, we could find some relation between the implant and all of these findings. Another case here, if you remember the case report, the first one with the silicone eliciting breast carcinoma. Here's just like the same, we have a mass here near the fibrous capsule and with some calcifications. Here's the ultrasound of this mass. So the ultrasound of this mass, it's just near the capsule, and here you can see some, probably it's not specific, this finding, but probably you have a discontinuity of the capsule here. And in this case, this patient has a 4-year breast augmentation with the implant. And here is the lymph node with silicone inside of the lymph node. So we have the bleeding of the silicone. So I don't have the implant of this patient, but we can see that there is a mass with the silicone bleeding. And this lymph node is this one, and this is the fibrous capsule. And here we can see the bleeding of the content of the inside of the implant through outside of the implant, through the pericapsular space. And here we can see the granuloma inside of the implant, inside of the intracapsular space. And here again, it's a DCI, an invasive ductal carcinoma. And what about sarcoma? Here, it's another patient that she had a sarcoma. The image is just like the same of the other patients. Here is the granuloma. We can see findings of the granuloma inside of the implant. And at the pericapsular space, you can find a lesion, a breast mass, a cancer. And it's a totally undifferentiated cancer. And this is the histology of sarcoma, probably in our theory, because we have the epithelial cells and the stroma, and if the injuries in the stroma could go to a sarcoma, and go to the epithelial cells goes to a carcinoma. And here's the histology with undifferentiated cells and the immunochemistry of the lesion. So confirming it's not from it's a sarcoma and not a carcinoma. So in summary, we presented a theory and hypothesis in breast cancer and silicone implants relationship, that the implant could eliciting a breast cancer, and we showed some evidence that cancer could be elicited by gel bleeding. We cannot affirm that, but we have a lot of evidence that must be discussed, I think. And one of the messages is imperative to detect gel bleeding, especially in the breast MRI, and to perform the diagnosis of the granuloma, because when we perform the diagnosis of the granuloma, we can mark this patient that she could have some problems in the future with her implants. And here's my book. It's I report my history, the story of my research of breast implants. It's the first chapter because it's when the voices of silence. The next one is the echoed voices, because I think all of the people are hearing the patient with the breast implant illness. In my opinion, all of these cancers, lymphomas, and Asia, and all of these are the breast implant illness. Some kind is more aggressive, and the most common are less aggressive, and it's going to be only the breast implant illness. So thank you for the opportunity here.
Well, thank you very much for all of this. I definitely wanted to hear more about this publication, because it's further than just the SIGBIC. It's one step further. So one of the things that you were saying in the presentation is you had two actual studies. You had the first woman that had her implants for the 6 months, and she had the carcinoma, and then you had the second case study, and then you went back, this is my understanding, if you want to correct me, then you went back and looked at all the MRIs, or you looked back at other cases. Is that what happened?
Yeah, we have in our study we have 4 centers, and in all of the centers we have the incidence of breast cancer in about 5% of the patients that perform breast MRI. Despite the indication of the examination. There are some patients that had cancer and the others that goes through a static procedure. But in all groups, in all places, in all centers, we have 5% of the patients with breast cancer. Not all of the breast cancers have relation to the breast implants, but some of them we saw they have similar findings, and they have contact to the capsule, and there is changes in the implant that were similar to all of them. This was the cases that I reported after the two cases. But unfortunately, we don't have all of the data, surgical data. But I think the two first cases, we have a huge material to support the theory.
And more studies.
Yeah, sure.
So what did you think, Robyn?
I did have one quick question. I noticed that in all of the slides, the tumor was always very distant or very close to the capsule. Did you happen to have any tumors that were distant from the capsule? In your
I don't think so, because here, just like the Barrett metaplasia of the esophagus, because to have the metaplasia, you need to have a chronic injury of the site. So we need to have the contact to the silicone all of the time. So when we have a distant tumor, it's probably the injury is not going to be recurrent. It's not going to elicit this morphogenesis, reverse morphogenesis of the cell. So it's going, the body can recruit some specialized cells to go on the place of the death cell. But when we have a constant injury, as we show here, so the silicone in contact to the tissue, probably we're going to have constant injury and making some cells deaf, and we couldn't have replace the cell with a specialized one.
So what are you working on next from this? Like, what is your next step?
My next
if you're
step
allowed to tell me, yeah.
is trying to, now I'm looking for more cases. When we have suspected cases of cancer in our centers, we are following them closer and to search for the implant shell and for the findings, and try to reach more cases of cancer. But I think the main message here is patients with breast implants and cancers, but they don't link the pathologies. So we always think that's incidental finding, and if we start looking for these patients with breast cancer and try to relate the cancer or to search for some changes in the implant, and to search if we have more cases of breast cancer that was elicited by the gel bleeding and the silicone. Because I think it's under diagnosis here in our clinical practice for today.
Well, one of our questions Robyn and I always talk about is it, or one of the hypotheses that we come up with, do you think that if we took those capsules and on every person that explanted, and instead of just letting them go, like send them to pathology, do you think that there would be that would be a better study?
Sure, there's going to have, but again, I think the cancer, it's hard. It's not an usual finding, because here I work in some reference places. So my patients, we have some bias here. But for sure, it's interesting to study the capsule and to search for metaplasia and what kind of metaplasia we are having in this space. And probably in some patients, and it's multifactorial, it's not one factor, but it's multifactorial. Some patients probably can go to elicit breast cancer, as we show here, different types of cancer, metaplasia of lesions with relation with the breast implants. So when we have more data and when we study more capsules and we search for these findings, probably we are going to understand more what happens to the pericapsular space with the implants. We need to have more researchers.
Yes, definitely. Robyn, any other questions?
No, I think I'm good. I mean, I also, I'm a breast cancer survivor, so I had my implants for reconstruction. And my friend Michelle and I, we always wonder if there's any statistics out there, and maybe you can point us in the right direction, or we can start a crusade on this, but we always wonder what the recurrence rate is in breast cancer women who either just had a mastectomy and chose to stay flat and never had implants, and those who reconstructed. I would love to see statistics on that, and I've looked for them. It's been a while since I have, but I'm curious to see if the recurrence rate is higher in the women who have implants, because, you know, they already did have cancer in their body, so their body's kind of predisposed to that possibly. And then I was just curious if the recurrence rate was higher. So that's a study we've been dying to see done for a couple of years now. So
yeah, it's difficult to say, because when we opt to go to our reconstruction of the breast, we are going to keep some some breast tissue there. So we are going to have more chance to have another recurrence of the cancer, because there is residual breast tissue there, and when you go flat, you're not going to have the tissue, and probably you're not going to have the cancer. Yeah. What's interesting, there's another research that I'm trying to publish. It's submitted to another journal, because all of the physicians said that, oh, nobody, the patient had the cancer, and she needs to have a breast. So we're going to put the implant. So she's a female, and she's going to change the some psychosomatic, yeah, and all of the people say, oh, you're going to stay flat. No, you need to put some breasts. You are female. We give much importance to the aesthetic and not for the cure of the cancer. And it's interesting in my research because we follow up patients with that went through breast reconstruction with radiotherapy and without. And we saw that patients that underwent hydrotherapy, the implant complications goes to half of the time that who didn't go through hydrotherapy. So and these patients have some complications. Most of them went through a second and third surgery, and most of them have symptoms of the breast implant illness. So I think that they changed the malignancy, the breast cancer, to a man-made pathology, that's the breast implant. And especially with this new techniques using the latissimus dorsi, we saw that most of the muscle used for the reconstruction during the time the capsule is going to make this muscle be diseased, and probably in many patients we're making some illness. She's cured for the cancer, and we are giving some illness for these patients. And this I found in a lot of patients, and it's sad, yeah, because she was cured for a cancer, and she got a new illness for the aesthetic procedure.
That happens a lot, I think, yeah, and a lot of complications as well.
But this is a personal option. I think some patients, they should go to the reconstructive surgery, especially because until the FDA allowed the implants, the silicone implants, that should be an option for the patients. But we need to be clear with the patients despite of the complications. So she needs to know that she can have an illness, a bad illness because of the treatment of the cancer. So I'm not totally against of the silicone, because for some specific patient, they are going to choose to use the implant. As for the cigarette, yeah, there are many patients that used to smoke, but in my opinion, we need to tell them that it's not a good thing until the FDA is going to ban the implants, because it's hard to understand how it's allowed something that we are seeing making a lot of illness for the patients, seen from the breast implant illness, like capsular contracture, to cancers, and like lymphomas that it's proved that we have. And only one more thing, the same pathway that we say here for the breast cancer is for the lymphoma, because the aggressive since in the shell of the implant we don't have any other cell than the lymphocytes and the macrophages, so the chronic reaction, it's going to recruit younger cells, and that's probably we are going to have the lymphoma. So all of the disease have the same pathway.
Very interesting. Well, thank you so much, Dr. Fleury, for presenting and letting us know about this wonderful study that you just did. And I know there's more to come, and we will be continued.
Thank you.
Thank you for the opportunity again.